If you feel tired all the time, B12 is one of the first nutrients worth thinking about. Not because it's trendy, but because low B12 can look like a dozen different problems. It can show up as fatigue, brain fog, tingling, mood changes, or just feeling off. And here's the tricky part. Some people eat enough B12, yet still end up low because absorption gets blocked. That means the real question isn't only what you eat, it's also what your stomach, intestines, and medications are doing to that B12. In this guide, you'll learn the most common warning signs, who's at higher risk, and the everyday factors that can interfere with absorption. You'll also learn what labs are typically used and why a normal number can still miss the bigger picture. The goal is simple: help you spot patterns early and know what to discuss with a clinician. Moving to slide 2. Vitamin B12, also called cobalamin, is a helper nutrient your body uses in a few critical systems. First, it supports red blood cell production, which affects oxygen delivery and energy. Second, it supports the nervous system, including the insulation around nerves called myelin. Third, it works with folate in DNA-related processes, which is why deficiency can affect fast-dividing cells. Your body stores B12 in the liver, often for years, so deficiency can creep in slowly. That slow drift is why people sometimes normalize their symptoms, or blame stress, aging, or poor sleep. Another important detail: B12 in food is bound to protein. Your stomach acid and enzymes have to release it. Then it has to bind to intrinsic factor. And finally, it gets absorbed in the last part of the small intestine. So B12 status isn't just about diet. It's a whole chain, and any weak link can matter. Moving to slide 3. One of the most common early signs people notice is fatigue that doesn't match their lifestyle. You sleep, you rest, you try caffeine, but you still feel drained. With low B12, fatigue can come from anemia, but it can also happen before anemia shows up. Some people describe it as low stamina, getting winded easily, or needing longer recovery after normal activity. You might also notice weakness or a heavy feeling in your legs. Another clue is paleness, or looking a bit washed out, because red blood cells may not be doing their job efficiently. And if your heart is working harder to move oxygen, you can feel a faster heartbeat or mild shortness of breath. None of these symptoms prove low B12 on their own. But if they cluster together, especially over months, it's a reasonable flag to investigate with labs and a medical history review. Moving to slide 4. B12 is closely tied to the nervous system, so neurological signs are a big deal. A classic symptom is tingling or numbness in the hands or feet, often described as pins and needles. Some people notice reduced vibration sense, clumsiness, or feeling unsteady when walking. Others feel burning sensations or unusual sensitivity to touch. Balance issues can be subtle at first, like meeting the handrail more often or feeling less stable in the dark. What makes this important is that nerve-related symptoms can progress if the underlying deficiency isn't addressed, and they can occur even when blood counts look okay. That's why clinicians take these symptoms seriously, especially when they're new, persistent, or worsening. Tingling has many possible causes, like diabetes, thyroid issues, or nerve compression. So the goal isn't self-diagnosis. The goal is recognizing that B12 belongs on the checklist. Moving to slide 5. Low B12 can also affect how your brain feels and how you function day to day. People often call it brain fog, slower thinking, trouble focusing, or feeling mentally muddy. You might notice memory slips, like forgetting names or why you walked into a room, more than usual for you. Mood can shift too. Some people feel low, more irritable, or more anxious, and they can't quite explain why. Sleep can feel less restorative, which then feeds back into fatigue. Now, it's important to be careful here. These symptoms are common and can come from stress, depression, iron issues, thyroid problems, or many other factors. But B12 is a known piece of the puzzle because it supports nerve health and methylation-related processes in the brain. If cognitive and mood symptoms show up alongside physical signs, that combination is worth discussing with a clinician. Moving to slide 6. Your mouth and digestive system can also send early signals. A well-known sign is a sore, smooth, or burning tongue, sometimes called glossitis. Some people notice mouth ulcers, taste changes, or a persistent metallic taste. Appetite can shift, and unintentional weight loss can happen in more severe cases. Digestive symptoms like nausea, diarrhea, or constipation can show up too, partly because the gut lining is a fast-renewing tissue and B12 is involved in cell turnover. Another clue is that low stomach acid can both cause digestive discomfort and reduce B12 release from food. So you can get a double hit: GI symptoms and lower absorption at the same time. Again, none of this is exclusive to B12. But if mouth soreness and digestive changes appear with fatigue or tingling, it strengthens the case for checking B12 status and absorption risk factors. Moving to slide 7. Some people are more likely to run low on B12 even with a decent diet. If you eat little or no animal foods like meat, fish, eggs, or dairy, your intake may be low unless you use fortified foods or supplements. Age matters too. As people get older, stomach acid often decreases, which can reduce B12 release from food. Certain gastrointestinal conditions raise risk, including celiac disease, Crohn's disease, or a history of intestinal surgery. A past gastric bypass is a major risk factor because it changes both acid and the absorption pathway. Another group is people with autoimmune conditions, because one specific autoimmune issue, pernicious anemia, targets intrinsic factor, which is essential for absorption. And if you've had long-standing unexplained anemia or neurological symptoms, that history itself is a risk marker. Knowing your risk category helps you and your clinician choose the right testing approach. Moving to slide 8. Let's break down absorption, because this is where many cases are missed. Step 1 happens in the stomach. Acid and enzymes free B12 from food proteins. Step 2 is binding. B12 first binds to a carrier protein, then later binds to intrinsic factor, a protein made by stomach cells. Step 3 is absorption in the ileum, the last part of the small intestine, where intrinsic factor helps B12 get taken into the body. Step 4 is transport in the blood, where B12 attaches to proteins that deliver it to tissues. If any step is impaired, low acid, low intrinsic factor, inflammation in the ileum, or transport issues, your B12 status can drop. This is why someone can eat B12-rich foods and still be low. It's also why different forms of B12, like food-based versus high-dose oral supplements, can behave differently in the body. The key takeaway: absorption is a system, not a single switch. Moving to slide 9. One of the biggest absorption blockers is low stomach acid, which can happen for different reasons. Chronic gastritis, including autoimmune gastritis, can reduce acid and intrinsic factor over time. Another common factor is long-term use of acid-suppressing medications like proton pump inhibitors or H2 blockers, which lower stomach acidity. Lower acid can be helpful for reflux symptoms, but it can also reduce the release of B12 from food. That means a person might absorb supplemental B12 better than food-based B12, because supplements don't require the same unbinding step. There's also a condition called pernicious anemia, where the immune system attacks intrinsic factor or the stomach cells that produce it. In that case, dietary changes alone may not be enough, because the core absorption mechanism is impaired. If you've had long-term reflux treatment, chronic stomach issues, or unexplained anemia, it's worth asking specifically about B12 and intrinsic factor-related testing. Moving to slide 10. The small intestine is the next major bottleneck.
B12 is absorbed in the ileum, so anything that inflames or removes that area can reduce absorption.
Crohn's disease often affects the ileum, and even mild chronic inflammation can interfere. Celiac disease can also reduce nutrient absorption more broadly, especially if it's not well controlled. Surgical history matters a lot. Removal of part of the ileum or certain bariatric surgeries can significantly reduce B12 uptake. Then there's bacterial overgrowth, sometimes called SIBO, where bacteria in the small intestine can consume B12 before you absorb it. Parasites like fish tapeworm are a classic but less common example. The practical point is this: if you have chronic bloating, diarrhea, unexplained weight loss, or a history of intestinal disease or surgery, low B12 may not be a simple eat more problem. It may be a can't absorb well problem, which changes the medical conversation. Moving to slide 11. Medications can also affect B12 over time, and the most discussed one is metformin, commonly used for type 2 diabetes and insulin resistance. Studies have linked long-term metformin use with lower B12 levels in some people, possibly by altering absorption in the gut. Acid-suppressing drugs, like we mentioned, are another big category. Some antibiotics can change gut bacteria, which may indirectly affect B12 status, especially if GI issues follow. And nitrous oxide exposure, sometimes used in medical or dental settings, can inactivate B12 in the body and has been linked to neurological problems in susceptible people. That's not a reason to panic. It's a reason to mention it if symptoms appear after repeated exposure. The takeaway is simple. If you've been on metformin, long-term reflux medication, or have frequent GI-disrupting medication cycles, it's reasonable to ask whether periodic B12 monitoring makes sense for you. Moving to slide 12. Testing for B12 can be more nuanced than people expect. The basic test is serum B12, but it doesn't always reflect what's happening inside cells. Some people can have low normal B12 and still have symptoms, especially if functional markers are abnormal. Two functional markers often discussed are methylmalonic acid, called MMA, and homocysteine. When B12 is low, MMA tends to rise, and homocysteine can rise too, although homocysteine is also influenced by folate and B6. Another important lab is a complete blood count, looking for large red blood cells called macrocytosis or anemia. But neurological symptoms can appear without those changes. If pernicious anemia is suspected, clinicians may order intrinsic factor antibodies or parietal cell antibodies. The right panel depends on your symptoms and risk factors. The main point is to avoid overtrusting a single number. Context matters, and interpretation is a clinical skill. Moving to slide 13. So what can you do with all of this information in a practical way? Start by noticing patterns, not single symptoms. If you have fatigue plus tingling, or brain fog plus mouth sourness, that combination is more meaningful than one vague complaint. Next, look at your risk factors: diet pattern, age, GI history, surgeries, and long-term medications. Then bring a clear summary to a clinician: what you feel, how long it's been happening, and what risk factors apply to you. If testing confirms low or borderline B12, the next step is usually figuring out whether intake is low, absorption is impaired, or both. That distinction matters because it can affect the form and monitoring plan a clinician chooses. Before we wrap up, one quick action step. If you're vegan or vegetarian, make sure you have a consistent, reliable B12 source, typically fortified foods or a supplement plan discussed with a professional. If this was helpful, subscribe for more evidence-based nutrition breakdowns, and comment, have you ever had your B12 tested? Yes or no? This information is not a substitute for medical advice. Health is not